Today, we are going to do a quick, high-yield review of retinoblastoma, the most common primary intraocular malignant tumor of childhood. Retinoblastoma is a highly important pediatric tumor because it arises from immature retinal cells and is strongly associated with mutations of the Arbone tumor suppressor gene. Early diagnosis is critical because the disease can threaten both vision and life if it spreads beyond the eye. This image beautifully summarizes the gross pathology, microscopic pathology, clinical presentation, and prognostic features of retinoblastoma, making it an excellent pathology review. Let us begin with the origin of the tumor. Retinoblastoma develops from primitive retinal neuroblasts, also called retinoblasts, which are immature neuroectodermal cells present in the developing retina. Normally, these cells mature into the specialized structures responsible for vision. However, when mutations occur in the Arbone gene, uncontrolled cellular proliferation develops, resulting in the formation of a malignant retinal tumor. Grossly, the tumor appears as a creamy white, chalky mass arising from the retina. The image shows this tumor occupying a significant portion of the posterior segment of the eye. One characteristic feature of retinoblastoma is the presence of calcification within the tumor, which appears as chalky white areas and is often detected on imaging studies such as CT scans. As the tumor enlarges, it may grow in different directions. One pattern is endophytic growth, where the tumor projects inward into the vitreous cavity. In this pattern, tumor cells may break away and float within the vitreous humor, a process known as vitreous seeding. Another pattern is exophytic growth, where the tumor grows outward beneath the retina. This can lead to retinal detachment as fluid and tumor cells accumulate in the subretinal space. Both vitreous seeding and retinal detachment are important because they indicate disease progression and can significantly affect prognosis and treatment planning. In advanced cases, the tumor may extend toward the optic nerve, creating a pathway for spread into the brain and central nervous system. Now let us look at the clinical presentation. The most common presenting symptom of retinoblastoma is leukocoria, often called the white pupillary reflex. Instead of the normal red reflex seen when light enters the eye, parents may notice a white reflection in photographs or during examination. Leukocoria is considered the hallmark clinical sign of retinoblastoma and is one of the most frequently tested examination points. Another common presentation is strabismus or squint, which occurs because the affected eye develops impaired vision. As the disease progresses, children may also present with decreased visual acuity, ocular inflammation, redness, pain, or proptosis in advanced disease. Early recognition of leukocoria is particularly important because prompt treatment can preserve both life and vision. Moving to the microscopic pathology, retinoblastoma belongs to the family of small round blue cell tumors of childhood. Under the microscope, the tumor is composed of densely packed primitive malignant cells with hyperchromatic nuclei and very little cytoplasm. These cells create the characteristic appearance of sheets of small blue round cells. One of the most important microscopic features is the presence of Flexner-Wintersteiner rosettes. These structures consist of tumor cells arranged around a central lumen and represent retinal differentiation. The presence of Flexner-Wintersteiner rosettes is considered highly characteristic of retinoblastoma and is an important diagnostic clue for pathologists. Another structure that may be seen is the Homer-Wright rosette. Unlike the Flexner-Wintersteiner rosette, the Homer-Wright rosette lacks a true central lumen. While Homer-Wright rosettes can be found in retinoblastoma, they are not specific and may also occur in other pediatric tumors such as neuroblastoma. The image also demonstrates areas of necrosis and large chalky calcifications. Tumor necrosis occurs because rapidly growing malignant cells outgrow their blood supply, while calcification develops within necrotic tumor tissue. Together, small blue round cells, rosette formation, necrosis, and calcification form the classic microscopic picture of retinoblastoma. The image further highlights the patterns of spread and classification. Localized disease remains confined to the retina and generally carries an excellent prognosis with modern treatment. As the tumor progresses, vitreous seeding may occur, where clusters of tumor cells float freely within the vitreous cavity. Subretinal seeding occurs beneath the detached retina and indicates more advanced local spread. The most concerning form of extension is optic nerve invasion. When tumor cells enter the optic nerve, the risk of intracranial spread and distant metastasis increases significantly. For this reason, optic nerve involvement is considered one of the most important prognostic factors in retinoblastoma. Several factors influence prognosis. Tumor size, extent of vitreous seeding, degree of choroidal invasion, and optic nerve involvement all affect outcomes. The genetic status of the arbone gene is also highly important. Children with hereditary retinoblastoma often have bilateral disease and are at increased risk of developing secondary malignancies later in life, including osteosarcoma and soft tissue sarcomas. Fortunately, with modern therapies including chemotherapy, focal laser treatment, cryotherapy, plaque brachytherapy, and enucleation when necessary, survival rates are excellent when the disease is detected early. To summarize, retinoblastoma is the most common malignant intraocular tumor of childhood, arising from primitive retinal neuroblasts due to arbone gene mutations. Clinically, it presents with leukocoria, strabismus, and decreased vision. Grossly, it appears as a chalky white retinal mass with calcification, vitreous seeding, and possible retinal detachment. Microscopically, it is composed of small round blue cells with characteristic Flexner-Wintersteiner rosettes, Homer-Wright rosettes, necrosis, and calcification. The most important prognostic factors include tumor size, vitreous seeding, choroidal invasion, and optic nerve involvement. Early diagnosis and treatment are essential because retinoblastoma is not only a vision-threatening disease, but also a potentially life-threatening pediatric malignancy.